Hi there. Hope you all are fine. And first of all, I am so sorry for not able to post regular videos for you because I was busy with a few family and personal commitments. Moreover, I switched my job from India to Bahrain recently, and therefore I was very busy in settling myself with this new job and surroundings here. To help all those who are preparing for EDIC Part 1, I have come up with few K types of MCQs with focused discussions in order to give you the idea for new MCQs which could be framed on same topics. So let's start. Regarding Guillain-Barré syndrome, it presents with weakness of the peripheral muscles and cranial muscles. So let's examine each statement for its truthfulness and validity. Okay, so you take a moment to read all the options. And regarding the first statement, what do you think, guys? Whether it presents with the weakness of both peripheral muscles and cranial muscles or just peripheral muscles? So the answer is this is true statement. GBS presents with weakness of both extremity muscles and cranial or trunk muscles, and the lower limbs are usually involved before the upper limb. That's the important thing you must remember. Okay, so it starts with the lower limb muscles first, and then it ascends bilateral and symmetrically. Okay, the proximal muscles may be involved earlier than the distal muscles. So this is also important fact. Trunk, bulbar, and respiratory muscles are also affected in varying proportions. So trunk muscles are involved in about 34% of cases. So this is trunk muscle, 34% of cases it is involved. And the respiratory muscles are involved in about 20 to 30% of cases. And this is the group of muscles which is going to require the ventilatory support. So about 20 to 30% of the patients with GBS require mechanical ventilation. So this is also important fact. Okay. Now the second option, the most common associated pathogen is Clostridium difficile is wrong. Basically, the majority of cases of GBS occur within a month of either respiratory or GI infection, in which GI or gastro infections are commoner. Infection with Campylobacter jejuni which causes diarrhea is one of the most common cause of GBS. Many other organisms are also implicated in the pathogenesis of GBS, like Epstein-Barr virus and cytomegalovirus, and also mycoplasma. So these organisms are also involved in pathogenesis of GBS. So this must be remembered. Okay, this is an important fact. Now the um, third statement, patients usually have varying degrees of sensory, motor dysfunction and autonomic involvement. So this is also correct. Guillain-Barré syndrome is an inflammatory issue, usually demyelinating polyradiculopathy or polyneuropathy, which is characterized by ascending symmetrical limb weakness. It starts from lower limb and ascends to upper limb and also sometimes bulbar muscles. And there is sensory involvement, and there is also the autonomic dysfunction. So regarding the autonomic dysfunction, many people think that it is not so common. It's actually common. Okay, so autonomic dysfunction is common in about two-thirds of the patient. Two-thirds of GBS are affected by the autonomic instability, which is manifested by pupillary dysfunction like pupillary abnormalities, mydriasis and meiosis both, and wide fluctuations in the heart rate. There will be tachycardia, tachyarrhythmias, okay, or atrial fibrillation, or sometimes severe bradycardia. There will be wide fluctuations in the blood pressures as well, and obviously you have to have the bladder and bowel history, so there will be reduced or absent bladder and bowel control in such patients. Now, the fourth statement, in acute inflammatory demyelinating polyneuropathy type of GBS, primary immune injury sites are myelin sheath and Schwann cells. This is correct. So we have three variants, okay, in Guillain-Barré syndrome, the most common ones. There are other variants also. There are about 9 or 10 variants in Guillain-Barré syndrome, you must remember, but the three are the most common. Acute inflammatory demyelinating polyneuropathy. AIDP is the most common one. Okay, and it in this type of variant, myelin sheath and Schwann cells are basically the primary target sites. Okay. Then we have axonal variety. In axonal variety, we have two subtypes, pure motor, okay, or motor and sensory both. So MN and MSAN. So in these, the common thing is the uh, axonal membrane is the target. Okay, that is axolema. Axolema is the target for autoimmune attack. Then third variety is the fissure, which is also very important variant, and many questions are asked regarding the Miller-Fisher variant, and we will discuss it later. So here I would recommend to go and read GBS from a fabulous chapter written by Dr. Vikas Bhagat and Abhijit Das, published in first edition of this book called Critical Care Medicine Bedside, Bench to Bedside. And it is very nice book for all the people who are interested in critical care medicine. Now the last option, the clinical hallmark of uh, Miller-Fisher variety of GBS is a triad presentation of acute ptosis, reflexia, and ataxia. So this is the wrong option, because acute ptosis is not the one of the clinical triad. Actually, it is external ophthalmoplegia, which is one of the triad. So clinical feature of Miller-Fisher subtype include ataxia, areflexia, and ophthalmoplegia, which may be accompanied by limb weakness also. So the weakness may start from above downward. So the first, the limb muscles are also affected, and bulbar palsy is also there. Okay, facial palsy, ptosis, all these facial uh, ophthalmic muscles are also get affected. An acute onset of external ophthalmic lesion is a cardinal feature. Ataxia tends to be out of proportion to degree of sensory loss. So clinical features of Miller-Fisher variety of GBS are quite opposite to what we see classically in Guillain-Barré syndrome, and you must be aware of that, because this is very common um, topic for the MCQs, right? So let's move on to the second MCQ. With regard to a patient who has a history of neuromuscular disorder, admitted in ICU and soon to undergo endotracheal intubation, succinyl choline use should be avoided in patients with myopathies and myotonia. This is the correct option. So succinyl choline use is very challenging in these patients, because in these patients there is higher risk of malignant hyperthermia, hyperkalemia, rhabdomyolysis, and cardiac arrest, basically hyperkalemic cardiac arrest, due to presence of extra junctional acetylcholine receptors. So there are extra receptors which are present in these congenital myopathies and myotonia patients, and that is the reason they have increased availability of ACH when we use the acetylcholine, and because of that there is higher chances of rhabdomyolysis and higher chances of hyperkalemia, acute kidney injury, and also the malignant hyperthermia, MH. Okay, and sometimes there is cardiac arrest. So you have to remember that in these patients, acetylcholine use should be avoided. Okay, so this is what I was talking about. The dose of acetylcholine must be reduced in patient with myasthenia gravis. Actually, this is a wrong statement, because myasthenia gravis is an exception where you can use succinylcholine, and if you are using, it should be used in about higher doses, double doses. Okay, so there is a relative resistance to this succinylcholine in myasthenia gravis because of decreased availability of ACH receptor. So in myasthenia gravis, what happens? ACH receptor are attacked by the autoantibody. Okay, so autoantibody attacks the ACHR, and then these are occupied, and that is why It is very difficult to create adequate paralysis for intubation. That is the reason you have to use higher doses of succinylcholine. So remember this fact, right? Now, regarding the dose of rocuronium, what should we do? So this is the second option. This is correct or not? Dose of rocuronium should be reduced in patient with Guillain-Barré syndrome. That is the uh, correct option, true option, because sensitivity to non-depolarizing neuromuscular blockers increases in these conditions owing to reduced muscle mass. So basically, in Guillain-Barré syndrome or any other myopathies, what happens is that there is a reduced muscle mass because of uh, what do you call the atrophy. Okay, so there is muscular atrophy or dystrophy, and due to this, they require lesser dose. Basically, 10 to 20% reduced dose is required to achieve adequate paralysis for intubation. And if you are using the muscle relaxant, non-depolarizing muscle relaxant, you should use atracurium. Atracurium is better than the rocuronium because it is self-degraded by the esterases in the blood. Okay. However, when you are using any muscle relaxant, be using the you should be monitoring the patient with the peripheral nerve stimulator. That's very, very important, and that will titrate or guide the dose of infusion of atracurium. So this is very important. And if you have cis atracurium, that is the best agent to use for patients in myopathies. What do you think about option D? Sugamadex can be successfully used to reverse restorative muscle relaxant. So if you talk about the reversal agent, the Sugamadex is very, very good drug, and that is the correct option. Okay, because in so non-depolarizing muscle relaxant can be of two types: isoquinoline derivatives and steroid derivatives. So Sugamadex work very well for pancuronium, vecuronium, rocuronium, etc. Okay, because it has been studied quite well. Majority of articles review the report successful use of Sugamadex to reverse the steroidal muscle relaxant, especially rocuronium in patients with neuromuscular disease. However, with Sugamadex, there is a unpredictability in response and uncertainty about the optimum dose. Okay, so don't think that we cannot use Sugamadex as actually best drug for reversal compared to acetylcholinesterase, which should be actually avoided due to danger of triggering muscle spasms in patients with myotonic disease. Okay, they may precipitate myotonia, so they are relatively contraindicated if you talk about the neostigmine, which we commonly use in other patients, but in patients with myotonic disease, they should be relatively contraindicated. And if we don't have anything else, then we should use the reduced dose. Now, from here, I would want to all of you to pay attention to question number 3 regarding the diagnostic lumbar puncture (LP). So those first option, cerebral herniation is a relatively rare complication. So this is a true statement because cerebral herniation is a rare complication and its rarity is about just 0.1%. Okay, that is very, very rare, but it usually occurs within 24 hours of LP. Therefore, a pre-procedural non-contrast CT scan should be done of brain, CT brain, and if you have suspicion of elevated intracranial pressure, for example, due to mass lesion or space occupying lesion, or decreased level of consciousness is there, GCS less than 11, or a recent seizure or brainstem sign, anything like that, then you should always be going for a CT scan, and if we could not do, then better to not to do a LP because in such patient there is a higher chances of cerebral herniation, right? So in any suspicion of mass or space occupying lesion or decreased GCS less than 11, or any seizure or any brainstem sign like pupillary changes, so you should observe pupils. If pupils are dilated, therefore not to go, or if there is a posturing of muscles or irregular respiration, any sign of neurological deficit, it is always better to delay the lumbar puncture, right? So there are few contraindications, so you should remember. So there are absolute contraindications and there are relative contraindication. And suspected epidural abscess, spinal abscess, is a relative contraindication to LP. Okay, because the clinical presentation of spinal epidural abscess may not be present always, like fever, back pain, and neurological deficit, and that is the reason lumbar puncture should always be avoided in patients with suspected SEA due to risk of spread of infection into subarachnoid space. However, bacteremia is not a contraindication. If patient has suspected bacteremia, is not a contraindication for LP. Now regarding option C, ongoing aspirin is contraindication to an urgent LP. That is the wrong option. Antiplatelet therapy with aspirin or NSAID has not been demonstrated to be clearly associated with increased risk of bleeding after LP. So it is recommended to suspend therapy when possible prior to elective LP, but if it is important to do diagnostic LP, or for any emergency diagnostic reasons, anticoagulation with low dose aspirin like 75 milligram OD dose of aspirin is not a contraindication for performing LP. Now regarding option D, newer oral anticoagulation, when they should be held. So this timing, you should have an idea about timing. So this is the correct option. Performing an LP is not recommended in patients with coagulation defects who are actively bleeding or who have severe thrombocytopenia. So any patient who has platelet count of less than 50,000, okay, or INR more than 1.4. This is the absolute contraindication. These are absolute contraindication for performing LP, and discussion with local hematologist is advised if you are in doubt. Lumbar puncture is very common and diagnostic procedure, but remember when to hold certain anticoagulation. So there is a list, I will give you the list about when to hold, but regarding option E, LP is considered safe after 12 hours of therapeutic doses of low molecular weight. So remember, therapeutic doses. If it is prophylactic, this statement would have been correct, but therapeutic doses of LMWH, you should wait at least for 24 hours. Okay, so this is important. You wait for 24 hours. So this is a very nice uh, photograph where different timelines are given. So for prasugrel, you must wait 10 days before attempting LP. For clopidogrel, wait for 7 days. For warfarin, wait for at least 3 to 7 days or 4 days. And for novel anticoagulant, you can wait for 48 hours or even 72 hours. And for low molecular weight heparin, if it is a therapeutic dose, wait for 24 hours. If it is a prophylactic dose, wait for 12 hours. And if the patient is on unfractionated heparin, wait for 4 hours. And for aspirin, there is no need to wait if it is a low dose aspirin. So remember this, very, very important for all the MCQs. Now we will move on to fourth MCQ. The following have been demonstrated to be useful prognostic variables in moderate to severe trauma brain injury. So prognostic models have been developed, okay, in predicting the outcome in moderate to severe traumatic brain injury. And we must remember two models: impact model, just name, and crash model. Impact stands for International Mission for Prognosis and Analysis of Clinical Trial, and CRASH stands for corticoids randomization after significant head injury. Okay, so these two models have been developed from a large database. These are mathematical models to predict the severity or severity of traumatic brain, to predict basically outcome after a traumatic brain injury. So you must remember the variables. Okay, so these two options are wrong. So ICP and sensory neurological deficit is not a part of the variables in these prognostic models. So crash model includes basically age and low income or high income country and GCS and pupillary reaction and extracranial injury and CT findings. Similarly, impact model is there based on extensive prognostic analysis. They have developed it and it predicts 6 months outcome after TBI. Okay, by entering the characteristics into the calculator, this is the online calculator, you can calculate or you can estimate the expected outcome at 6 months. Whereas impact gives you two important prognostic things information: mortality at 14 days and Glasgow outcome scale less than 4 at 6 months. How many patients will be having Glasgow outcome scale less than 4, and what will be the mortality after 14 days. Okay, so this is important. This is crash model and that is your impact model. Remember these two models for prognostication in moderate to severe TBI. So that's all for today. Thank you so much for your attention. Follow me on YouTube and Instagram and ask queries. I will be very happy to answer all your queries, and best wishes for your exams. Thank you. Bye bye.